I'm very pleased to introduce our next speaker, largely because it's Grace. So let me just help by sorting out my laptop so that it doesn't cause any delays. But we've got two speakers talking about their experiences with PHEM feedback. And this predates getting Grace involved in the project. So isn't it a time before she was subject to all of my emails?
So many emails.
Without any respite. So let me, while I just do this, why don't you...
Thank you. Okay, so hello again. I'm now going to speak to you from a purely clinical perspective. My role is a paramedic in the east of England. Thank you, Matt. I had jinxed my shift from the start. What I should have done, what I said to my crewmate over breakfast was, I really fancy a trauma today. It's been a while. It's almost like saying it's a quiet day, isn't it? I should have wished for the winning lottery numbers instead, because this was the call that came up. A 30-year-old male pedestrian had been hit by a car, who's lying on the ground alert. These are the details I've been passed down the MDT. So I get a little excited, jump in the truck, and off we go. We're only about a mile from the job, so not a lot of time to process what I'm about to see, but we're ready for it anyway. As I get out of the vehicle, I can't see a car in sight, but there is a pedestrian lying on the floor. They're lying on their back, shouting up at a police officer, so airway is clear. As I step out of the ambulance, I get a bystander report as to what happened. Now, it was a strange mechanism of injury, and I still to this day have not put my finger on it. This patient was seen to come around the corner on top of the bonnet already, so traveling on the bonnet at 30 miles an hour. The car then came to a halt, and the patient was thrown 5 meters from the vehicle, landing on the floor. The two men inside the vehicle then got out and proceeded to punch the patient until he lay very still. They then got back in the car and drove away. I couldn't understand how that patient had got on top of the bonnet. It wasn't witnessed. Had he been hit and lifted onto the bonnet? So had he already received a traumatic impact and then was lying on top of the car? Or had he actually provoked the driver, banged on the bonnet, I'm not sure, got on top of the bonnet in full health, but then thrown from the vehicle? A little muddled was my head as I approached the scene, but I'm very aware that I need to look after the patient's neck. C-spine is a priority, as I don't understand the mechanism at all. So my primary survey initially for this patient was quite good. A clear airway. Patient, like I said, yelling at the police officer. I suspected there may be alcohol involved. He was breathing, but as I exposed his chest, I could see bilateral bruising across his rib cage. But he had good air entry at this stage. He was tachycardic, but only at about 100 beats per minute. Understandable, given the situation. We continued to try and get a story from the police, from the bystanders, and as I'm doing that, I noticed that the patient is abusing the officer less and less, and as I look down, has become unresponsive. His breathing rate has slowed to about 4 a minute, and I can't see any chest rise. So I act. We insert an OP and 2 MPs, and I start to BVM this patient. For the non-clinicians, I'm now ventilating the patient. I can't get any chest rise with this patient at all, so I upgrade this. I asked the student I'm with to do a 2-person bag technique. Maybe it was my technique. We'd worked together, and I got a really good seal around this patient's airway, and yet I could not inflate the chest. It felt like the mechanics of the chest were no longer as they should be. I know that every clinician in this room is itching to tell me what they would do next. The patient's SATs have dropped from 96 to 93%. He has become increasingly tachycardic, now sitting at 130 beats per minute. And as I said, his rest rate is now 4 and had actually dropped to 0, but we're supporting these ventilations. For those who are not clinical, my impression was that this patient was suffering a bilateral tension pneumothorax. This is when air is trapped between lung and chest wall and squashes the lung so it can't inflate. If the lung is squashed and not inflating, the chest won't move. So this made sense with the patient I had in front of me. And he did also have bruising to the chest, so that added to the picture. However, those who are clinical will be considering, Grace, did you miss a head injury? has this irregular respiratory pattern actually as a result of a head injury. The patient didn't have any bruisings, no contusions around his head, but yes, it could have been. But I disregarded this because the mechanics of ventilating this patient were extremely difficult. Equally, did he have an internal hemorrhage which had dropped his GCS? I was giving tranexamic acid at the time because I could not identify if the tachycardia was due to a hemorrhage. So, I performed a needle chest decompression. This is where you insert a needle into that airspace between chest wall and lung and hope to reinflate these lungs. I looked up at the student I was working with, a little shaky, and I said, I'm a bit nervous actually. I don't do this often. It's not a daily skill. I said, but I'm going to talk it through out loud. And she said, oh yeah, should I've not done this yet? Oh, so there I am, talking it through out loud, looking for reassurance, and actually haven't necessarily got it there. I also realized that I had never performed this without another paramedic or a doctor on scene. I mean, they may not have even been looking over my shoulder, but at least they were in the room. And here I felt completely isolated on my own. I made the decision, and I inserted bilateral needle chest decompressions. As a result of that, my saturation rate percentage increased to 96%. I could suddenly inflate the chest. I particularly noticed that my BVM was much easier once I'd inserted a needle into the right chest. My tachycardia dropped to 100. So suddenly the patient isn't as tachycardic, and I'm thinking, maybe I've done good here. But that didn't stop me feeling a little anxious about the whole thing. I pre-alert the hospital, let them know we're coming. We're 2 minutes away. So I arrive looking a little something like this. Sweat dripping off my head, still attempting to BVM the patient, who's now respiring at 8 per minute, so there's some laryngeal movement there. I'm struggling. We're also now running into A&E. I'm walking and BVMing, and anyway, it's quite a normal job, isn't it? I'm making it sound dramatic. We arrive in the A&E department, in the resus department, to a whole team of trauma specialists that have come down to meet us. I give a handover and I step back. I hear them say, yes, I can confirm the patient does have a pneumothorax on the right-hand side. And I think, yes. I step back next to a doctor who's observing the whole scene, and he takes one look at me, and I said, oh, what do you think? Expecting a pat on the back, high five. He said, well, we'll never know if that pneumothorax was there before you got involved. Oh, we'll never know if you shoving that massive needle into his chest is now the cause of the tension that he has. I was completely deflated. All that adrenaline absolutely hit the roof, and I walked out feeling anxious, stressed that I'd done the wrong thing. And I'm sure there's a few people in here who could also say they felt the same on various jobs. It doesn't have to be these high trauma jobs, but this one was. So I walked out of the department, and it was the first week of the PHEM feedback project. I'm not involved at this stage, and I see this poster on the wall. Yes, Matt, I could benefit from that. This patient was hard to manage, he was critically unwell, he was diagnostically difficult, and now I'm unusually emotive. That's not what that one stands for. So I apply for feedback. I take the ED number from the patient, and I go and meet a debriefer, an approved senior ambulance clinician, and I ask, can we put this through? Do you think it's suitable? Yes, it is. She couldn't tell me if I'd done the right thing or not. Nobody could. Only the people reviewing that patient could do that. So I go through the entire loop, and I receive feedback. About 3 days later, I get feedback. I can confirm that this patient had a right moderate pneumothorax found on diagnosis in hospital. He also had left rib fractures, which suggests that he had had trauma to the chest that was new and could have potentially caused a pneumothorax on the other side of the chest. I felt a little reassured by this, but that wasn't all I got. So I'm quite happy with that. Oh, good. That was right. I did do the right thing. But actually, it was the rest of the report that put my mind at ease. I received this massive, in-depth report that actually you can't read from there because there's so much on it. I felt so valued that somebody had spent the time to go through this patient case, to look for references from NICE guidelines, from JR Calc, to say, yeah, given the patient that you had, that was absolutely appropriate to do what you did. Who cares, this doesn't say it in there, who cares whether that was a pneumothorax before you arrived or not? Given the patient you had in front of you, you made a safe clinical decision for that patient. Now, this is full of resources. There's also guidelines there that I could look up. I not only received that, but I also received the CT imaging. The CT imaging of the right pneumothorax. And so if air is black, you can see on this side of the screen, the air is in between the chest wall and the lung. And actually, we're compressing the lung, and it's being squashed against the thorax. And very courteously, they then sent me the image, the CT image, with the chest drain in situ. I'll give you a minute to find the chest drain. Took me a while. And actually, that's another point in these reports. The X-rays are explained to us. They are explained, thank goodness, because that is not our speciality. So within the debrief, me and this, it was a manager at the time, sat down and talked through this case. Not only had I had a whole team of doctors invested in the care that I gave this patient, but now a senior clinician was sat down with me talking it through. It felt so important that I was valued, that my well-being was protected, and that had that actually been a bad outcome for that patient, that news would have been broken to me a little gentler than had it landed in my inbox at 2 o'clock in the morning. I can tell you that actually that patient was discharged home 2 days later, no head injury, and both lungs inflating. So as part of a self-improvement project, I had such a good experience with the PHEM feedback service that me and Matt got serious in our talks about how can I get involved. This is so important. This is exactly what we all need as clinicians. How am I supposed to learn from my mistakes or from the really good things I'm doing? Just because a doctor makes a comment in an ED room does not mean that my practice is poor. And actually, that's the standard of feedback we were getting before this project came on. Okay, so not wanting to keep all of these findings to myself, Gio and the team at Princess Alexandra Hospital put together quick cases that we then sent out to a lot of the East of England clinicians. This landed in their inbox. It was a summary of my case, completely anonymized, of course, a summary of my case. And actually, it answers my queries. It shows people what I was thinking. It shows people what answers I got and what I've learned from that. And there was a second page to this with all the references that I'd had before. So we can all learn from this. Equally, there have been some, so since being a part of the project, I also self-nominated as a debriefer. As we've been doing the debriefs, and Anne in the room has been doing them with me, and I'm very grateful because she really kicked it all off. We've noticed many recurrent themes, and this is one of them, the Scarbosa criteria. Hands up if you've seen this. Yes. So, detecting whether an acute MI is present on an ECG that has left bundle or is paced. This is a real favourite of mine, and it's something that I'm teaching because we're starting to say you don't have an excuse now. You can't just say that's left bundle. We need to really differentiate whether this is an MI. Now, this came up on 3 separate reports from PHEM feedback, and Gio communicated that with me, and as a result, I was able to put this into a recent cardiac day that I did with the East of England Ambulance Service, trying to disseminate it further. So, benefits for frontline clinicians, moral boost, yeah, morale boost, definitely. It makes you feel like you're invested in. It makes it feel like not only the debriefers care about what you've been through that week, but also the people in hospital who, on a stressful day, might give us an unhelpful comment like they did before. It feels purposeful because it's debrief-led. Somebody sits down with you. I'm not just reading that, yes, he did have a pneumothorax. Instead, we're talking it through. And that feels so good to talk about clinical practice like that. And I don't know about you, but it's been a while since I've had these hearty discussions with people. Encouragement to reflect and self-direct learning. It gives us points to reflect upon and where to put our learning, where to put our resources. Gives you greater confidence and perhaps competence for future cases. I've certainly gone over my needle chest decompression method. I've also learnt that you shouldn't use the tape that's in your pocket to secure the needle chest decompression because it gets covered in green fluff, students covered in green fluff, and then looks really messy as you roll in. It takes a bit of explaining. And also gives us closure on difficult cases, and hopefully will lessen burnout. We're all exhausted mentally in our well-being at work when we're continually exposed to cases like this. And so hopefully being invested in and learning from it, taking the positives from these cases, will make a difference. Okay, so that's enough from me. Well, until later. And I'm going to introduce another case from Tony Stone, but he's at the back, so it may take him a little while to come down. Thank you for listening.
Wonderful to see so many people here supporting this brilliant event. My name is Tony Stone. I'm a critical care paramedic with Essex and Herts Air Ambulance, and I'm also employed as their patient liaison manager. I always feel a bit of a fraud talking at events like this when I look in the audience and see so many people that I have so much respect for, so thank you for letting me talk today. Just a case presentation really, and how we've used the PHEM feedback. So let me tell you about this case. So I was actually working on Helimed 55, which is our aircraft that's based out of Northfield Airfield, not far from Harlow. On board, we always have the 4 people, so the captain, the co-pilot, the paramedic, myself, and we have a pre-hospital care doctor as well. This was June 2018, and it was a day shift. It was a lovely, lovely warm day to be wearing a big, thick, heavy flight suit, as you can imagine. And we were dispatched just before 3:30 to a male, 16 years old, motorcycle versus wall. So quite a big mechanism, you're thinking already, aren't you? Kind of classic HEMS job, if you like. And it was 9 minutes from the base to the patient's side. Nice and quick, nice and quick. It was a very uneventful flight, nothing to report, and we report that as an alpha landing. So effectively, we landed right next to where the patient was. We were very close, landing right next to where the patient was. The scene, I think there's a picture. Here you go. Here you go. So it was a public bridleway, you can see there, leading to the bridge over the canal, which you can quite clearly see. The entrance to this bridge had these big bollards, and obviously there was a barrier either side of the bridge to stop people who were walking from falling off. There was a motorbike just in the ditch, just off the bridge. Have I got a laser? Yeah. There you go. There was a motorbike just off the bridge, just off here. And there was quite a lot of damage to the motorbike, and that obviously gives you a lot of clues about the potential mechanism and the forces involved in this impact. The patient itself was lying on the bridge, surrounded by quite a big group of friends. And the history was provided by a friend who was quite calm. They tell us that the patient was riding the motorbike without a helmet. So again, I think probably another alarm bell there. Riding approximately 30 to 50 miles an hour. Reality, they probably don't know, do they, is the reality. That was what the bystander told us, but I don't think anyone will really know how fast truly this person was going along the bridleway. Apparently they lost control just before the bollards, apparently. They didn't hit them, lost control before the bollards. Collided effectively with the edge of the bridge, the wall, head first, and had a sudden de-acceleration injury. Pattern, I suppose. The friend was adamant that there was no loss of consciousness, because they were there pretty much straight away, but the patient itself was unable to recall the incident. And when we saw the patient, when the friend was telling us that the patient is complaining of this mid-back pain, that was what the patient was complaining about, this mid-back pain. And there was an ambulance crew on scene, an absolutely fantastic ambulance crew, absolutely fantastic. So here we go, here's the primary survey of the patient. So the patient was maintaining their own airway. They had no B compromise, and this is just from the notes, so no deformity, no chest wall tenderness, no surgical emphysema or crepitus. They had bilateral chest movement and air entry. They had some grazes to the bilateral sternoclavicular prominences and some grazes to the left anterior shoulder, but otherwise no compromise. C, no compromise, strong radial pulses, abdo-pelvis normal, long bones seemed intact. D, GCS 15. maybe 14 and a half, but 15 fundamentally. Denies any memory of the accident, is occasionally repetitive, certainly not agitated, certainly not really amnesic, but just occasionally a bit repetitive, gives his name, gives his year of school, gives us some information, tells us quite crudely that he's in quite a lot of pain, and pupils are active and he's moving all 4 limbs. He does have a lot of grazing to the left side of his face. His eye is very swollen, and he does have some blood in his nose. He's got a right distal radius ulnar fracture, fracture to the left hand, and I don't remember noticing this, but apparently a laceration to his toe. So that's quite a detailed primary survey there, I think we will all agree. So there we go. So on the face of it, quite a stable-looking patient, isn't it? I think if you look at that, you think, oh, fairly stable-looking patient. But you can't help but look at this motorbike that is pretty trashed, this solid wall that he's hit, and the report that he was going somewhere between 30 and 50 miles an hour. All this stuff is going around in your head, isn't it? Here are our observations. I'll just put them all up. So I think you'd all agree the patient, from the observations point of view, heart rate of 98, respiratory rate of 14, SATs of 99%. I think that was on O2 at that point. I think the land crew too. BP, fairly unremarkable, maybe a little borderline high for a 16-year-old lad, but I don't think it's too concerning looking at it right there. And fundamentally, I say GCS 15, just a little bit repetitive at times. I think temporary VM was done. I'm pretty sure it was done. I can't actually generally remember, but it wasn't recorded in the notes when I reviewed this case. So our plan with this chap, he's on the floor, he's complaining of his back pain, he's really complaining about his back pain. He's letting us know in no uncertain terms that his back is really hurting. So, closed off, we did put some oxygen on him until otherwise. Put some monitoring on him, gained some IV access. We gave him some analgesia. We actually gave him an analgesic dose of ketamine and a little bit of fentanyl just to try and get on top of that back pain quite quickly. Not to sedate him, but just to try and get on top of that pain quite quickly because he was quite distressed by it. We decided to package the patient with spinal precautions just because of this pain that he was describing in his middle of his back. We splintered his wrist. And then we had the triage decision. Go to the trauma unit nearby, Harlow, or do you go to the major trauma centre? What's your thoughts? Who wants to go to the major trauma centre with this patient? A few people. Who wants to go to the trauma unit with this patient? Good. So by the process of elimination, everyone else wants to discharge him on scene, I guess. And that's probably not the right answer. I'm just going to throw that one out there. Okay. Yeah, do you know what? I did have something in the back of my mind. I can't really put my finger on it, a bit of a gut feeling. It's difficult, these patients. But fundamentally, you know, using the EEAST trauma triage tool, which I'm sure a lot of you are familiar with in the room. For those of you not, there's physiological and anatomical criteria. He was fundamentally what we would call major trauma negative. He wasn't meeting the criteria here for say, straight diver. That doesn't mean we can't go to the major trauma centre. It just is a tool to help aid our decision making. But we thought, in the interests of actually doing everything correctly, we'd have a discussion with our on-call consultant. So we're very fortunate that we have an on-call consultants team who we can run incidents by for maybe any advice we really want on scene, maybe triage advice particularly. And we described that it was a high velocity impact with no helmet. And we described the injuries, described the fact the patient was quite stable. We did explain we had some concerns over like axial loading injury, potentially, this sudden deceleration, maybe head first into this wall. We sought basically after advice about our triage decision, where should we go? And we agreed with the on-call advice as well that given the stability, the fact that this patient was fundamentally GCS 15, movable limbs, that we would go to the trauma unit. And I think that's what the majority of the audience thoughts were on the way that I presented the case. And so we made that transfer by land. We were right next to very close to the hospital, so it made sense to go by land because we could get there a lot quicker than if we were to load the patient into the aircraft and fly there. We gave the patient some further analgesia en route and antiemetic. He's feeling a bit nauseous. And we had a great response from Harlow, as we obviously trauma called this patient, and we had a great response from their trauma team. So this is where we thought, do you know what, perfect case. Patient's gone to Harlow. We can use this fairly new at the time, I think we agree, wasn't it? This PHEM feedback process. And it's been absolutely brilliant, absolutely brilliant. So this was the summary. Okay, CT head. So there was some contusions and some evidence of swelling. They had a non-displaced midline fracture, the inferior aspect of the occipital bone. A zygomaticomaxillary complex fracture. I think radiologists have some great words for Scrabble, don't they? I think that's... you get about 1 billion points for that, wouldn't you, really? There we go. So that's a complex fracture here. They had a non-displaced fracture along the ramus of the left mandible. So that's the head. CT spine, no bony injury or fracture seen in the cervical spine. Chest abdo-pelvis, so there's a burst fracture of the T4 vertebral body, probably why he was complaining of quite a lot of discomfort in his back. Fair play, I suppose. A lightly fracture through the left-sided lamina at T5. No rib fractures, no pneumothorax or pleural fluid. Pelvis intact, no bony injuries seen, etc. Limbs, fracture of the left distal radial, displaced fracture of the, what does that say? The third of the right fourth metacarpal. Again, you can read that there. And then he was transferred to Edinburgh's MTC due to complex facial fractures, thoracic fractures, and a need to have a specialist left eye assessment. And that transfer, it always worries you as a pre-hospital clinician, doesn't it? It always makes you think, oh, do you know what, should we have taken them to the MTC the first time round? Now, I'm going to come on to that. I'm not always sure that necessarily needs to be the case, but he was transferred to MTC. So the learning, this is the important part of all of this, really. So a huge thank you to Matt and Grace for all the hard work that's been done on this PHEM feedback, because it is hugely, hugely helpful. I think it's fair that we did identify and anticipate most of the reported injuries in the pre-hospital phase. I think that's fair to say. We probably did underestimate the complexity of the facial fractures. Our concerns around the spinal fractures, axial loading, did prove correct. And the cerebral contusions, yes, that is always a worry when you see that on a CT, but there wasn't something that was immediately operable that would have needed neurosurgical immediate intervention. We're very fortunate at Essex and Herts Air Ambulance, and obviously our neighbouring air ambulances as well, that we have a lot of time to have debrief on the cases that we attend, led by one of our pre-hospital care consultants. And actually, the patient follow-up and outcomes hugely, hugely enhance this process. And this is what this PHEM feedback process has done. In the past, we might have said, yes, okay, we lifted within 5 minutes, tick. We wore the appropriate protective equipment according to the standard operating procedure, tick. We administered the right dose of ketamine according to the SOP, tick. But actually, before all of this, and before some other models we put in place to learn about our patient outcomes, we didn't actually know if we'd actually identified the injuries that the patient had and actually maybe taken them to the right place to treat them injuries. So this is why this process is so valuable, particularly for us as an organisation. So, just for completeness, the final outcome of our patient, he did undergo a spinal fixation, he did undergo internal fixation of less radius, and he did have a surgical repair of his facial fractures at Addenbrooke's. And he was discharged home, thankfully, 10 days after the incident, and has subsequently returned to work, which is a fantastic outcome. So I have really flown through that case, very mindful of time, but I just really wanted to emphasise again how valuable this patient outcome data is for us as an organisation, particularly, and I'm sure for all of my pre-hospital colleagues sitting in the room, about learning how we can improve patient care going forward. And I think I put a tweet out earlier, and I said that feedback and debriefing directly improves patient care, and I think that's what we all want to achieve every day we turn up at work. So, thank you. Any questions?
Okay, so we're going to have a question and answer panel now. If Jon wouldn't mind coming back up, and I guess I should sit just in case.
All right, thank you so much to all of our speakers just now. Obviously, they're sharing with them cases that they've been to in the same way Jonathan did earlier. This is difficult to stand on the stage and talk about what you did and be truthful about it and put yourself open to both criticism and praise. So thank you all for speaking so candidly about each of your three cases that you've described. We'd like to open up to some questions for our speakers. Seeing as it's my wife, I should... So the question, for those who couldn't quite hear, was if the feedback you'd received wasn't quite the same, would it have influenced your further management, and also would it have influenced the way that you have thought about feedback since? Do you want the microphone? This is why Grace does this stuff.
I think I would have been heartbroken. Yeah, devastated, disappointed in my practice. But that's not to say that I shouldn't find out. And I think that's the key, actually, to open yourself up to, yeah, okay, I'll let someone else have a look at my case is quite a big move anyway. I'm not sure if I did the right thing, but I'll have somebody have a look, and then somebody else is going to have a look because the debrief is also going to know about it. So now I can't hide it quite so easily if I did do this wrong. But actually the overarching thing for me was that I needed to know, because if I keep making that same decision based on those same findings, I'm only going to cause more harm than good. So in terms of patient well-being, it was a good idea that I did find out. Yes, but from a personal point of view, my pride would have been destroyed.
And a quick follow-up?
And then to the second speaker, again, a really amazing talk, and all three were I wondered, in terms of decision-making and transforming advice, if you've got any quick tips for those of us following the tools of a really busy shift in the middle of the night, dealing with basically with all of those risk factors that you listed. I think we can all clinicians and think, tick, 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 tick. Is there anything you could say is kind of a quick thing we can do in that setting to help us?
Yeah, great. So specifically, what tips do I have for helping to deal with difficult decisions when you're at those lows of your circadian rhythm? So the 4 a.m. nadir is what you're particularly worried about. So the first step is just acknowledging and recognizing that that's a potential weakness in your own performance. Make it the way you approach decision making when you're fatigued needs to be different to how it would be when you're not in one of those fatigued states. So whether that means you reduce your cognitive burden by only taking responsibility for one decision at a time, breaking off some of the some of the distractions, and actually being willing to say, actually, I'm not in the right frame of mind to discuss this right now. Does this need to be dealt with urgently, or can you give me 5 minutes to finish off what I'm already undertaking, and then I'll answer your question about your patient? And that's what I spend my whole night shift doing as an emergency medicine registrar, is not so much dealing with my own decisions, but the fact that my junior colleague needs to put their decisions on to me, and we need to be aware of how much of that, how much decision fatigue actually affects us. But as I said in the beginning, awareness of it is the first step, and having some insight.
Any further questions? We have one from Laurie. So, yep, go for it.
So one from Twitter, which is for Matt and Grace, really. Does the debriefer ever say, no, this case shouldn't go to the friend feedback team? How does that get dealt with at that point?
Yes, they do. We've got we can decline requests because we are a finite resource. We need to focus on patient-specific information. So, for instance, we've turned down requests which are things that you could look up in a textbook or online resources. We also have to decline some if the identifier used isn't what we're entitled to do through our legal basis. But we can discuss that a little bit later in our final talk. A good question. We don't find out about that, and perhaps that's something that we need to make sure that if we feel our clinicians aren't being listened to or entertained, we've been very lucky at Harlow, they have been, that they can come to us directly or Grace directly should they have concerns. But I'm keen to get one more question. Yes. You are jumping the gun a bit. We will discuss this in a little bit more, in which case one last question, seeing as that was a quick one. Gentleman at the back.
One for Tony. You sort of talk about how it could be criteria, and totally agree with that. However, sort of looking at the case that actually really did benefit from going up to ambulance at a later point. Has this affected sort of your cognitive bias in regards to clinician suspicion? And have you safeguarded against sort of, again, jumping the gun in the future?
So how has this information changed your decision-making for similar cases in the future, I think?
I think the first thing to be very mindful of, and I can be guilty of this, is that thinking just because a patient has been subsequently transferred to a major trauma centre from a trauma unit doesn't mean they necessarily needed to go there in the first instance for their immediate care. And I still think actually this patient probably didn't need to go to a major trauma centre immediately for their first care. It's very difficult. I think it's very difficult to safeguard against it. And I think all of us as clinicians, we use a huge amount of gut feeling in our decision making, don't we? We have tools to help us and advise us and support us, and we have an external phone a friend that we can use to help make decision making. But ultimately, it's very difficult, I think, sometimes on these scenes to decision. I think I just have to use your gut feeling a lot of the time with the patients in front of you. Use the tools that you have to make these decisions. Sometimes you will get it right, sometimes you probably won't get it right, but it's these feedback loops that we're going to have now that are going to help us learn from these mistakes.
There's just one more thing I would say about that as well, and there's a typical way of teaching that happens in both paramedicine and emergency medicine of the worst case mentality. And it seemed to be the safest way to approach things, that if you always concentrate on what this could be the worst case scenario, you'll never miss a bad diagnosis. That method of approaching medicine carries huge amounts of risk, because you actually then pass on other effects. So if that patient that had no possibility of having a pulmonary embolus, but has now got a diagnostic label that's gathering traction, with each step in the process, it becomes so much harder to back away from that diagnosis, and for somebody to then just say, I'm going to stop this in its tracks and say, this is just a lower respiratory tract infection or a viral infection because the label has started. And it's easy to just assume that, because we'll rule that out with a CT scan, but actually that carries risk. So we need to always be careful about using the worst case scenario mentality when approaching our interactions with patients, because that label that starts can carry on through the rest of the journey, and it becomes harder and harder with each step to back away from that.
Fantastic. Thank you very much to all our speakers. Can we please give them a round of applause?